Well, good morning, everybody. My name is Jens Chapman, and this is a great honor to have all of you around the world here for our November 7th virtual Spine Journal Club. And this is the Global Spine Journal Club. We thank AO Spine for their partnership in this with SSF. And we're always live from a great location. We've done live from Dubai, live from Bangkok, and live from Rio. And here we have live from one of the great cities on this planet Earth. That's San Francisco. So we're live from San Francisco. And we have two young, great faculty who have had an amazing impact. Both are dual spine fellowship trained, Dr. David Gendelberg and Dr. Ashraf El-Naga. Dr. El-Naga did both orthopedic trauma and spine training after his residency, and Dr. Gendelberg did a spine trauma fellowship at Harborview, as well as a minimally invasive surgery in LA. So both are very well trained, but they're also super productive academically, and they're actually going to be our chairs of our upcoming spine trauma course in December of 2025. So look for advertisements for this. And we use this occasion for the Global Spine Journal Club to review articles of subspecialty interest from the Global Spine Journal over, which is very large now. We have well over 5,000 articles, and we're very proud of our reviewers. We're grateful for our reviewers and the many submissions around the world. So we want to really thank everybody for coming together. And we found so many interesting articles in there from past topics that we thought spine trauma was a welcome new opportunity to kind of delve into that in greater detail. And with that, I'll pass the microphone off to Dr. Gendelberg and El-Naga. And again, we're live from San Francisco. Look forward to your program.
Thank you, Jens, for having us. It's truly a pleasure to host this journal club, and I know me and Dr. El-Naga are really looking forward for the trauma course as well. We selected 3 interesting articles to be discussed today, and we have our fellows Matt Easton, Mohammed El-Amoudi, as well as our resident Sarah Kiani presenting the articles for us. Ashraf, do you have anything to add?
Yeah, no, I mean, I think it was especially with the Global Spine Journal, it was really difficult to sort of find 3, to choose from amongst all the articles to find 3. But we really wanted to choose articles where where there's a little bit of debate as to the treatment. So one of the common things that we find is, especially with our first article, is there is sort of a couple different religions out there, whether people follow the TLIX classification in terms to guide their decision making, or the AO spine thoracolumbar classification. So our first article will sort of look at the data surrounding both of those, and maybe we'll hand it over to Matt to start us off here.
All right, let me just share my screen. Thanks again for having us. Always really enjoyable to take part in these journal clubs and all the Seattle Science Foundation educational options. So my article is, which is the superior thoracolumbar injury classification tool, the TLIX versus the AO spine, 2013 systematic review. This was published in the Global Spine Journal in 2025. So fractures of the thoracolumbar spine can be either managed surgically or conservatively, and we have various classification systems to help with that decision-making process. There is, as Dr. El-Naga said, debate about what is the optimal classification system to use in clinical practice. The TLIX score, which was created by Dr. Porcaro in 2005, uses 3 variables to determine fracture severity and care: the morphology of the fracture, the integrity of the posterior ligamentous complex, and the neurologic status. And then the AO spine system and the subsequent thoracolumbar AO spine injury score, or the TLAO-SIS, was introduced in 2013 and 2016 respectively. And these use fracture morphology as well as neurologic status and patient-specific modifiers to determine fracture severity. And then the TLAO score provides some treatment recommendations. So this is a systematic review aimed to determine which tool is superior in inter and intra observer reliability, in agreement in terms of conservative surgical management, and then how CT and MRI influence the performance of the classification systems. This is just an image of the TLIX score. I'm sure most people are pretty familiar with, but going up, I think the key things about this score would be that a burst fracture is just one classification, and that is given 2 points. And then obviously the posterior ligamentous complex, that is I would say, much debated or much talked about in terms of like determining what is a suspected versus an injured, and it also requires an MRI to appropriately evaluate. This is a busy slide, but this is the AO spine TL thoracolumbar classification system that shows you your type A's, B's, and C's. I think most people at this point are pretty familiar with this system. Personally, I was not super familiar with the scoring system, so that was something that I had kind of became aware of through researching this article. But it applies scores for various fracture types and as well as neurologic status, and then modifiers. And any score that is above a 5 is operative, and any score that is below 4 is conservative, and then 4 and 5 is a gray zone in this system. I think a few things to just point out. The M1 does not require an MRI, and it is presence of tension band injury is indeterminate, and that gives you 1 point. So I think that's a key difference where you don't need an MRI, you can just sort of apply that. And then also it delineates between an incomplete and a complete burst, with a complete burst getting 5 points, which automatically puts a fracture into that gray zone, which is a slight difference from the AO, or a major difference from the TLIX score as well, which is where 2 is a burst and puts you in the conservative management. This is how we do, reliability with the Cohen's kappa score, and just kind of wanted to put this up here for everyone to see. So this was articles were retrieved in April 2023, looked at from 2000. We looked at the inclusion criteria were studies evaluating TLIX, AO spine, or the TL score, and it looked at either inter or intra-observer reliability, kappa score, agreement validity, and then the imaging modality performance. These are in patients over the age of 18 who sustained thoracolumbar fractures with or without spinal cord injuries. They excluded pathologic fractures, cervical fractures, sacral fractures, or those studies with duplicate cohort data. And then this was the data extraction was performed independently by 2 reviewers. Kappa scores were extracted for reliability studies. For these agreement studies, they looked at the concordance between the tools recommendation and the clinician's treatment plan in terms of conservative management versus surgical management. And then they looked at, for imaging, whether the imaging changed the decision making. So 21 studies were included in the final review, 11 reliability, 6 agreement, and 4 imaging. In terms of the reliability for our results, the inter and intra-observer reliability was on average superior for AO spine versus TLIX. For the AO spine score, the fracture type, in terms of fracture type scoring, type B injuries were consistently the lowest in terms of the reliability of classifying them, which makes sense because there's some, once again, that involves the posterior ligamentous complex. And I think that's where the crux of a lot of these difficulties of classification come in. And then on top of that, fracture subtype, an A3 versus a 4 or a B2 versus a 1 had less reliability than fracture type. So the clinicians were better at determining whether something was an A or a B or a C. For the TLIX score, for the final score, there was fair agreement. We had a kappa of 6.6 in one study and 0.23 in another. And in the studies that included MRI, post-PLC inter-observer scores were fair to moderate agreement. So I think clinicians are relatively good at that, but not perfect. This is just the table kind of showing all the studies. And this is for the AO spine, this is the reliability. A couple of things to note: the Reinhold et al. Study that has the highest, 0.81, 0.71. They were involved in developing the AO spine classification system. So the authors believe that they had a lot of familiarity with using the system. And I think with that system specifically, having familiarity with it helps, probably with any system, but with that system, with the AO spine particularly, it helps in terms of classifying. And then Chang et al., which had relatively low scores, were relatively inexperienced clinicians in terms of making that determination. This is the TLIX score data that once again just shows the range of kappa scores. In terms of agreement, which actually I think is maybe a more interesting thing to look at, both the TLIX and the TL-AOS-IS had excellent clinical accuracy regarding conservative treatment. So they were good at determining that. The AO trauma scoring system showed superior agreement for surgical treatment recommendations as opposed to the TLIX score. And this finding was driven by 2 studies that treated quote-unquote stable burst fractures, or TLIX scores of 2, surgically due to concerns about postoperative kyphosis. So that was Joachim and Santander et al. Those 2 studies had the biggest disagreement. And then Santander also had relatively low scoring for the AO scoring, and they treated all AO or most AO 3s and 4s with surgery, regardless of ligamentous complex stability, which influenced their scores. And then in the 3 studies that directly compared the 2 scores, the AO spine score was superior in terms of conservative and always superior in terms of surgical concordance. And this is just those studies right here. And then imaging, the CT was sufficient for having a good performance on the AO spine scoring system, which makes sense. MRI is not required for that scoring system. And then the TLIX obviously performed better when it had the MRI, which makes sense to me because an MRI is sort of a required component of getting a good TLIX score. There was one study that that looked at TLIX inter-observer reliability without an MRI, and obviously the PLC inter-observer reliability was not great because they didn't have that MRI. And this is the imaging modality. So in terms of like kind of conclusions here, AO spine outperformed TLIX in terms of inter and intra-observer reliability and agreement, specifically for surgical decision makings. Whereas for conservative decision making, both scores were adequate in terms of deciding when to use non-operative management. You do not need an MRI to improve the accuracy of your AO spine clinical score. And the authors recommended that the TL-AO-SIS score be used in clinical practice, though they do note that this is, these are all retrospective trials and that perhaps a prospective trial should be initiated to build upon these findings. In terms of limitations, relatively low quantity of studies, and I think that the quality of some of the studies the authors noted was a little bit questionable. There's a lot of heterogeneity in terms of these patient numbers, in terms of the observers. Like, are these people familiar with the scores? Are there people who are not familiar? Study methodologies. So it does limit maybe the generalization of these findings. I think a big sticking point with this is that AO spine is a fracture morphology score, technically not a decision-making tool. It just, the TL-AO-SIS score is a decision-making tool, but really the AO spine is just fracture morphology, whereas the TLIX score is a final score. It's a decision-making tool. It's looking at, ligamentous stability. So I think you could argue it's a more complex metric, and so it makes sense that it would have a lower inter-observer reliability. And then these were all weighted these were only one study. This is a concept also I was not super familiar with, a weighted kappa versus an unweighted kappa. And so this study didn't look at the severity of disagreement, i.e. like, if I do a TLIX of 3 and then a TLIX of 2, that doesn't really change my decision making, even though the kappa, that would technically be a different score. And it's much more important to know, like, are you scoring something as a 5 versus a 3? And so how big are the changes in the scoring? And we don't have an idea of what that is. So does the AO spine system outperform the TLIX? I think, in my opinion, it allows for more nuance in terms of the description of burst fractures. I think it gives you more of an option to treat a quote unquote stable burst fracture surgically, because you have the ability to, have an AO A4, which is a score of a 5. And then if you think there's an indeterminate PLC injury, or you think there's maybe potential for kyphotic changes down the line, that gives you a 6, which gives you the go ahead to perform surgery. Whereas, for the AO spine system, you have to first of all get an MRI and have a suspected injury and have a burst fracture, and it's a little bit more, I think, a little bit more work to get to that point. And then this was a letter to the editor that was published in the Global Spine Journal that sort of once again brought up the conflation of classification reliability and clinical utility. And they bring up, I think, a good point, which is like the Glasgow Coma score, which, I don't know the nuances of what's a 9 versus a 10, but it does kind of give you a quick and dirty, like, is this operative, is this not operative? I think that the TLIX score has some utility, especially for like residents or, early trainees, to kind of say, like, it's easy to kind of understand. And I think there is some value in terms of quickly thinking through the concepts of neurologic status, of fracture morphology, of a PLC structure, and coming up with an idea for a treatment option. So I think there maybe is value to both, though certainly going forward, I'm probably going to, I personally think about the AO spine classification system in terms of morphology when I'm thinking about these fractures. And that's all I got. Thank you. I'd love to answer any questions.
I have a question for Dr. Easton. So nice presentation, bring out some very important highlights, also in the discussion from your attending. At UCSF, you see a lot of trauma, spine trauma. So what is the lingua franca at 2 in the morning when you, Dr. Easton, call Dr. Elnaga to describe a thoracolumbar injury? What are you going to use language-wise?
So We do not staff the trauma at Zuckerberg directly. Is that so? I actually am not totally sure exactly what language you guys use, but I believe it's fracture morphology. I talked to the residents about it. I think you guys really just want to know the morphology of the fracture and the stability. I don't. Correct me if I'm wrong. Are you guys normally using the TLIX score? Like asking, like, is it TLIX 5, TLIX 2? I don't think you guys are doing that. You're just more like when I look at like the staffing WhatsApp group that we use.
Well, we'll defer to Sarah for this one.
Yeah, no, definitely. We just go with fracture morphology and, basically describe the factors on the TLIX score, but fracture morphology, posterior ligamentous complex involvement, neurological deficits. And then I think that's a lot more straightforward. Does a lot more.
Yeah, the issue that we kind of have, if you tell someone's a TLIC score of 4, I can't necessarily know how that fracture looks, and I feel like a lot of missing data when I try to imagine that fracture in my head. I think whether it kind of ignores whether one end plate is involved, two end plates involved, degree of comminution, things like that. And so I think the TLIC score falls a bit short in that standpoint, as well as I also think that the kind of the tension band aspect of it muddies the water about it as well. If you look at the same at the people from Jefferson, they performed their MRI studies where they looked at the sensitivity and specificity of predicting tension band rupture based on MRI and then going to the OR and seeing if it was violated. The kappa score was quite low. And so I feel like the AO spine classification is a bit more straightforward. I could paint a picture of the fracture in my head, and then use that for my clinical decision making.
Yeah, I mean, I think the important thing to realize is, these sort of both these, classification systems or scoring systems sort of came out at different times, and they've all sort of marched us forward to our current understanding. I mean, when the TLX came out, like it really formalized this thought of, when you're assessing a spine injury, you need to think of those three elements. Yeah, the bony injury, the neurologic status, and the PLC. It really got people focused on like what's happening, how does the injury affect, um, your resistance to, kyphosis. So I think that was, you know, yeah, very important, at the time. As David said, if someone gives me a TLX score, it's hard to know what to make of it, what the plan is. It might guide me as to whether or not I need to do a surgery, but not what surgery to do, right? And that's where, an understanding of the fracture patterns, as provided by if you could categorize it according to the AO classification, then you could start. First, it gives us a language to, compare treatments, so we can then analyze burst injuries as we will, in the coming article. But then also say, let's say a C type will get, a long segment fixation. I think this, we sort of, a couple people have touched on the PLC, assessment of the PLC. I mean, that's it's still difficult to do whether and you still need to do that whether you're going to use, either system, right? Because, a PLC disruption, if you have a CT scan and you're unsure about the PLC, I mean, the injury could still be a B type injury in the AO classification, or it could be an A type, So that diagnostic, the scoring system or the classification system doesn't give us any clarity as to whether or not a PLC injury is present. We still need to assess that, so.
And that's where probably that's where the lack of reliability in terms of AO type A versus B is probably coming in. It's like that gray zone between,
Yeah.
Yeah. And I think another gray zone kind of comes in between the differences between an A3 and A4. The TLX score doesn't necessarily differentiate the two, while the AO spine does differentiate whether one or two end plates are involved. And we all know that there are also regional differences on how to treat A3s and A4s, and so I think that also adds some variability.
I guess my question maybe for Matt is sort of going forward in your practice, like how would you like assess like the PLC, like in like these gray zone issues, you know?
Well, I think there's a value in terms of it depends on the patient. I think it depends on the mechanism of injury. If it's something where I'm feeling unsure about whether to treat something operatively or whether it's unstable. I mean, if you can get standing X-rays and look to see if there's a focal increase in kyphosis, I think that demonstrates some insufficiency of the posterior ligamentous complex. I certainly, like, at least in my training and residency, we would get MRIs, and we were constantly, Dr. Gundelberg brings up that study which showed that the MRIs maybe not, or it's overcalls PLC injuries is my understanding, but like certainly like looking at the facets, looking for like fluid, looking for signal in the flavum and the interspinous ligament. I think all those things would factor into the decision. So that would probably be, I would probably get an MRI and a standing X-ray, and if the MRI looked okay, I mean, there's going to be some signal, and the standing X-ray didn't show too much kyphosis, that would lean me towards non-operative. But if it looked, if the patient couldn't stand, couldn't get those X-rays, that would lean me more towards an operative discussion.
So this is great stuff. Let me just weigh in for a second. So first of all, it is amazing and frustrating and subject for a lot further investigations that roughly 50 years after we started having, actually 70 years after we started having the first attempts at formalized classification in thoracolumbar fractures, we still have an open subject on how to have a universal fracture language that is accepted by everybody, that's meaningful, that allows us to categorize injuries and allows us to also analyze injury severity. And that's amazing to me in the big picture. I do want to make another advertisement for our upcoming spine trauma course, and we'll have Dr. McAfee here. We'll have some great visiting faculty here, and some of these people have actually written some of the original papers. The commentary by our Mayo friends in the Global Spine Journal is very critical here, because the AO classification was meant to be a comprehensive redo. Yeah, that's the perfect slide by Dr. Sarraj, who's written some great articles, by the way. They pointed out a really important thing, and that is that TLIX was meant to be a screening tool to try to quantify injury severity. The guidance towards surgery or not was kind of done by Dr. Vaccaro et al. At Jefferson to try to understand what our European friends, who have a very much lower surgical threshold than what we have, prompt them to do, and to try to start comparing results. Because here in North America, we actually treat quote stable injuries far more non-surgically, whereas our European friends, if there's a fracture, they'll be very prone towards doing a very elegant minimally invasive surgery. So they wanted to, so Alex, Dr. Vaccaro really wanted to kind of just quantify injury severity and then correlate that to outcomes. He then himself also prompted, together with a number of us, a comprehensive redo of the main problem of the AO classification system, which was that it had 64 subcategories, and we want to simplify it. Now, this is maybe, I hope it was accomplished, but I don't think it was accomplished, but it's by far the most tested kind of a general lingua franca of spine trauma, A, B, C, and that stood the test of time. We remain frustrated that this has not become the official general classification language. But again, classification and severity scales are two different entities that should not be subsumized. So I just want to editorialize and reflect a little bit on the history and how everything came around. But Alex Vaccaro has a key role in trying to change the game and then reclassify everything. Just thanks for letting me editorialize.
No, I think that's great.
And I also
think
continue, thought.
Yeah, no, I think I was going to move on to the next article. So yeah.
Let me just stop sharing my screen.
Yeah, I mean, especially with the global variation, I think Mohammed's gonna, tell us, how that led to, this further, research and the need for research and high-level research, especially for these for burst injuries, which can, in the TLX classification can, a lot of them, it's probably the most common way that we end up in that indeterminate sort of score for whether or not to operate. And so, all right, Mohammed, take it away.
Thank you. That's actually a great segue into my section here. So the article I'm presenting actually has been written by a mentor of mine. Would like to honor him, Dr. Marcel Dvorak. It is a privilege to present his work today. It's authored by Dr. Dvorak, who was my mentor during my residency training at University of British Columbia, Vancouver. His guidance shaped my approach to spine surgery, and discussing his research feels like a fitting tribute to his legacy as a surgeon scientist. So the title of the article is Surgical versus Non-Surgical Treatment of Thoracolumbar Burst Fractures in Neurologically Intact Patients. It's a prospective international multi-center cohort study. So as an introduction, thoracolumbar burst fractures, AO type A3 or A4, are common traumatic injuries that are associated with significant burden to patients and society. It's a lot of controversy. Optimal treatment without neurological deficits is controversial, as prior studies have yielded mixed and inconclusive results. The equipoise is lacking on a global consensus as well. And as was previously mentioned, surgical advocates prominent in Europe report improved radiographic alignment and a more rapid return to normal activity. Non-surgical advocates adopted widely in North America cite a lower cost and fewer adverse events. Those are the two different train of thoughts. So the objective and hypothesis, the main objective was to determine whether surgery leads to a more rapid improvement of disability measured by the minimally clinical important difference, MCID, in the Osworthy Disability Index, ODI. For methods, this study design is an observational, prospective, multicentric cohort study. It compares surgical versus non-surgical treatment. Setting and population, it utilizes 14 international sites across North America, Europe, India, the Middle East, and Australia to capture a unique global portrait of practices. Inclusion criteria, neurologically intact patients between the ages of 18 to 65, with acute less than 10 days AO type A3 or A4 burst fractures between the levels of T10 to L2. And so they gathered about 198 eligible patients that were enrolled. There were about 122 surgical and 76 non-surgical. The exclusion criteria was anybody with osteoporosis, neoplasia, previous surgery, polytrauma, to keep it consistent. So the intervention, the treatment allocation was basically pre-decided. It was based on the standard of care at each institution, the treating surgeon's preference. It's not randomized. It leverages the local expertise and strongly held preferences to create the environment of equipoise. Non-operative includes everything from early mobilization, bed rest, with or without external immobilization. And an operative intervention includes everything from posterior, open, single, 2 levels above or below, and below, percutaneous, anterior, or anterior posterior combined. The primary endpoint the study is focused on is the time to achieve the minimal clinical significant in terms of ODI value. This is defined as an improvement of 12.8 points. And that's been based on previous studies that signifies an improvement on the ODI from a baseline within 1 year. The statistical analysis looked at ODI measured at discharge, then at 2 weeks, and all the way up to 2 months intervals for a period of 2 years. The time to event analysis was also used, including Kaplan-Meier survival curves and the Cox proportional hazard models to compare the time to reaching this MCID endpoint. So now looking at the results and discussion, the baseline differences, the groups were not perfectly matched. This reflects the selection bias inherent to an observational study. In terms of race, non-operative was more inclined towards the Caucasian population with about 89.5 versus 77% with p-value of 0.025. And operative is more common in the Asian population with 20.5 versus 8% with a similar p-value. In terms of severity, as previously mentioned, surgical patient had a greater proportion of more comminuted A4 fractures and high energy trauma. So those are typically operated, and that proportion is 50.8% as opposed to 26.3% with a very significant p-value. Non-surgical patient had a higher mean baseline ODI scores, which is 62.3 versus 54.1, indicating that they were more disabled at the time of baseline. And so this table here represents the kind of the international distribution of where surgical and non-surgical treatment really varies by continent, and typically more towards European versus North American. So in terms of primary outcome, the MCID, the median time to achieve this clinically significant number in ODI was similar between the two groups. Log rank was 0.5. So the surgical group reached it within 25 days, and it's pretty broad confidence interval. Similarly, between the non-surgical group, 25.5 days. And you can see here that the two lines along the Kaplan-Meier graph are pretty much overlapping all the way across. Okay, so they did a post-hoc analysis to see, okay, what is a minimal disability needed? A post-hoc analysis that was focused on the time to achieve minimal disability, and ODI less than 20 point, absolute less than 20 point, showed a potential trend towards a shorter time for surgical group. It's 69 days versus 82 days, though again, not statistically significant, 0.057. The adjusted Cox proportional hazard ratio was 1.39. That indicated that surgically treated patients may be more likely to achieve faster improvements. The secondary outcomes they looked at were satisfaction. And in fact, satisfaction was high in both groups, with over 80% of patients being extremely satisfied or very satisfied at 1 year and 2 years. There's no statistical difference between the mean time to return to work between the two groups. That was another important secondary outcome. Complications, 3 in the non-surgical group and 3 in the surgical group. In the non-surgical group, that required delayed surgery for mechanical pain, progressive deformity, and in the surgical group, the 3 patients required revision surgery for instrumentation issues. So there's several limitations I want to point out. The selection bias, the study design was not randomized, and the treatment allocation was based on surgeon preference, which introduces inherent selection biases. For example, more severe A4 fractures are often treated surgically. The outcome measure validity. Now, the ODI was designed for chronic low back pain and has not been validated in the acute spinal trauma population. The relevance of ODI and its MCID value may be misplaced in this context. Diagnostic uncertainty. Challenges remain in the diagnostic value of the posterior ligamentous complex injury. In fact, about 20% of patients in the study received a pre-treatment MRI. That reflects a very different global financial and resource availability constraint between different places. Subjectivity. The ODI, like other patient-reported outcomes, is a subjective, is affected by mood, expectations, and external factors. So that's another limitation there. So in conclusion, as far as the main findings are concerned, surgically and non-surgically treated patients demonstrate a similar outcome regarding the time required to achieve a meaningfully improvement in disability and MCID and ODI at 1 year. The future direction indicates that while surgical patient may potentially reach minimal disability faster, this requires additional large-scale studies to make that confirmation. So the critical need in this case here is future investigative efforts should be directed towards creating a validated outcome measure tools in spinal trauma, as opposed to just disability, to reliably assess acute recovery and treatment efficacy. So that's it. Thank you.
Yeah, no, Mohammed, thank you so much for, a great review. I mean, this was, this is, I mean, in terms of, multinational studies regarding in spine trauma, this is probably one of the largest studies that we have. And I think, we always, I think that what the driving thing for this, the reason for this study is just, it's just the environment of equipoise, right? Because equipoise is I mean, I know how I want to treat it. David knows how he wants to treat these injuries. The Europeans know how they want to treat it, and there is a lack of consensus, and the variation is just so great between like when it comes to these injuries. And that's generally what we mean by equipoise. I think, we always hold, like in this setting, I do feel that an observational study that's driven by care locally, does provide some high level care, because it's almost like an intention to treat. Um, and so, but yeah, no, so I don't know. I mean, Mohammed, how would this like study like affect your, how you approach burst fractures?
Well, I guess it goes to show that there's a bit of science and art to this kind of management, and even with limited resources, limited MRI, outcomes are very closely similar. So the way it affects me is having a very good conversation with the patient about risks and benefit of surgery versus non-surgery, because outcomes tend to be similar, and we don't have enough answer to push one way or another, except if it's very clearly a bad A4, as this study has shown. I think a very good kind of conversation with the patient is what I'm going to be doing, and being upfront about the data we have and what the risk and benefit look like for them.
Yeah, what always interests me is what with these studies is obviously this study had a large European cohort. They were the largest of all, but I also wonder how much of those operative patients would have been treated non-operatively elsewhere, and how they would have been done. Like when you look at the total numbers of operative versus non-operative fractures in this study, like in my mind, A3s and A4s tend to be a non-operative fracture, and so the fact that you had more operative interventions, the non-operative shows a lot of the differences in culture and consensus, and it's kind of difficult to predict how they would have been done had they been treated otherwise.
Yeah. Yeah, no, I hear what you're saying. But I think the the time to improvement, I think uh is something that's, we always, especially like I think my main take home message is I still have to think about how to treat these patients. It's
Mhm.
really the local context matters,
Yeah.
the patients matter, especially if someone needs to return to work, like this would, push me towards considering operative, intervention. And I would really encourage, the listeners out there to look into some of the additional sub-analyses that this group has published. There's a great paper on like cost utility that followed up from this study that showed like early return to work in the subset of patients that were treated operatively. Um, and so, yeah, I mean, I think we still need to think about how to treat, still need to think about, patients and what we're treating. And so, um,
Mohammed, this is Jens in Seattle. Thank you so much for this great presentation, but also recognizing our dear friend who departed way too early, Dr. Marcel Dvorak, who is a close friend of mine, and it can't be expressed enough in words what a phenomenal human being and surgeon and scientist. You said it all. He was. And this study was very important because it actually, for the first time, at great expense, thanks to AO Spine and with a global effort of multiple different cultural circles, quantified recovery of patients. I know there were a lot of debates about going into this, and the only really good study we had before that was by Kirk Wood, now at Stanford, who basically showed us that surgical care actually was inferior to non-surgical care due to a higher complication rate and more pain. Now, the devil's in the detail, and the images that he showed, and he's been here at our spine trauma course many times, are actually pretty profound. They were very massive surgeries done with multiple level fixations. And again, in our spine trauma course on the 19th and 20th, we'll have a chance to kind of review modern approaches. But these are pretty brutal surgeries that were done, and they had like I forgot what the numbers, but a almost double-digit infection rate, if memory serves me correctly.
Yeah.
So this was very eye-opening at the time. He had a long-term follow-up, which again did not show any great differences. This is really well done. It really plots out a significant timeline, and again just pairs the options that are out there. And I think you hit it on the head when you said non-operative versus operative. So, Mohammed, in your background as a Canadian trained surgeon, the infamous problem in Canadian care, from my perspective, was that their non-surgical approach was no bracing. Can you talk about the non-surgical care in greater detail? How did that look? How was that standardized? How was that kind of put together into one treatment category?
Yeah, so this, as far as how I've been doing it at the university I worked at in Vancouver, when it comes to non-surgical treatment, we prioritized functionality, range of motion, and being active and moving. And so we avoided putting things on them and risk of developing pressure ulcers or making the patient lose a bit of confidence in getting to move with physiotherapy. And so that's kind of why we're a bit more aggressive with the physio in terms of the non-operative care. But with that being said, we did pay close attention to how well they were doing with serial x-rays and clinical follow-ups, just to make sure that they are maintaining their alignment. So we basically kind of got the best of both worlds. We were always ready to switch gears if needed, but at the same time, we didn't slow down their progress so that they build confidence, maintain their functionality, and get back to work sooner if they choose the non-operative route.
And in the paper, how was that handled? Were most patients braced? Were most patients treated kind of expectantly for the non-surgical side? And how many crossovers from the non-surgical to the surgical side were there?
Oh, I didn't get that sub-analysis for the crossover part, so I'm not entirely sure. But I can mention, though, if I go back here, as far as the non-operative option, the more common, the percentages wasn't mentioned, but the more common was early mobilization without external immobilization. And in terms of the operative technique, they would do posterior open, single level above and below, as in terms of the most commonly utilized approaches in both categories.
Because that's a big deal, because just anecdotally, I'll just say that in the wintertime, which is coming on now, we have a lot of US Americans who had neurologically intact thoracolumbar fractures seen in Vancouver and then being discharged without a brace. And they'd literally call on the road down I-5 towards the US side and said, we need to be seen for our fracture. They didn't put us into any brace. And the point that I'm making is there's a cultural expectation of treatment. And in our culture, it is braces. And the Canadian literature has largely dominated this topic. So our board answer nowadays is this optional. But if you look at this, the 4 studies, 3 of them actually come from Canada. And for most US Americans, if you don't have a brace on patients and there's a problem later on, you'll be faulted, just medical legally speaking. It's not a black and white situation, but in general, patients in our country expect to be braced and kind of cautioned. And having the timeline of recovery is also super helpful. That was done in this study. But again, I think this was a fantastic study that really put a unbiased timeline and quality of life expectation into what these fractures mean for patients.
Yeah, no, yes, I completely agree. We've moved sort of in our practice away from bracing, and it does take a little bit of talking to our patients to tell them, hey, like we're looking, you talk to them about the data, but then like I also encourage patients to say that, hey, we want to maintain your muscle strength, and I don't want you relying on a brace. And then most people are, pretty amenable to that. Mohammed, you did make a point earlier, on the tail end there about the use of the ODI and how it's not specifically designed for spine trauma. And I completely agree with you. And I would sort of encourage folks who are like looking at, studies to do studies regarding spine trauma to look at the AO Spine Prost as, a potential, PRO measure because, our current tools, in the setting of trauma, you can only rely on patient recall, to their pre-injury state. There are some limitations to that. And we need a way to, a better tool to quantify the acute loss of functioning, which I think the AO score does. So
yeah, and the thing is with a patient who's relatively active and intact, like they'll have a low ODI score, and it's sometimes hard to differentiate those minor changes.
Great presentations, Matt and Mohammed. We're going to have Sarah round it up for us. We're going to shift gears to now we've potentially operated on the patients, and we're faced with a question as to whether or not we need to do a anticoagulate a patient. So this is a question that we often perseverate for because of the risks of both treatment and non-treatment in our minds. And I think this is one of those things where the data points us in one direction, but clinical practice is still somewhere else. So
Go. Okay. See my screen. So I'll talk about the timing of chemical anticoagulation administration in spine trauma and its impact on venous thromboembolism, bleeding, and mortality. And this was a systematic review and meta-analysis. So patients with acute spinal trauma, especially with spinal cord injury, have a high risk of venous thromboembolism. There's symptomatic VT, sorry about that. There's a rate of 9 to 11% of patients in spinal cord injury. And then data says a rate of 5 to 26% in patients without spinal cord injury. But despite the high rate of VT, there's still hesitancy to prescribe VT prophylaxis due to concerns about bleeding. So the goal of this study was to identify whether an early initiation of VT prophylaxis is efficacious and safe. So specifically, the study aimed to compare whether early, less than 48-hour VT prophylaxis versus delayed VT prophylaxis is warranted, and whether there were any differences in efficacy and safety between early and late administration. For efficacy, they looked at DVT and PE, and then for safety, they looked at major bleeding and mortality. The study was a systematic review and meta-analysis looking at adults with spinal trauma with greater than or equal to 10 patients, and they looked at rates of DVT, PE, major bleeding, and mortality with early versus delayed anticoagulation. From an initial 2,948 studies, 103 underwent full text review and only 9 met inclusion criteria. Of these, 5 looked at early versus late anticoagulation using a 48-hour time point and assessing rates of DVT and PE separately. And they included a total of 13,110 patients with about 6,500 in each group. And the other 4 were included in the systematic review, but not the meta-analysis because they did not meet the same criteria. Overall, they found moderate to high quality studies. So starting with the outcome of efficacy, they found that early anticoagulation was associated with a significantly reduced risk of DVT, with about an 80% lower odds of developing a DVT than the late anticoagulation group. They did find moderate heterogeneity in the studies, but it is still considered in the lower end. There was also a 60% lower odds of PE in the early anticoagulation group with high consistency among studies. Regarding safety, there was no increased risk of major bleeding, which was defined as a hemoglobin decrease of greater than or equal to 2 units, transfusion of greater than or equal to 2 units, retroperitoneal, intracranial, epidural, and other intraspinal bleeding, or bleeding requiring cessation of anticoagulation. There was also no increased risk in mortality. So just a little bit about the sensitivity analysis that they did. They used funnel plots, which show data from multiple experiments and look at whether the overall data is symmetric around the pooled results. So above this is an example of a symmetric funnel plot. They used this for sensitivity analyses and found no or mild asymmetry for all results. An asymmetric study, something like this, says that there might be a bias in publication of data. Given that there were only a small number of studies for each outcome, I think this is this sort of sensitivity analysis has limited utility, but overall, the larger studies did pool at the top like this, as we would expect it to, and their effect sizes were similar to the pooled effect sizes. Overall, the data supports early chemoprophylaxis within 48 hours as both safe and effective. They applied this to both operative and non-operative trauma patients, but there was limited data in non-operative patients, and only one of the studies that they looked at actually included non-operative patients. There was no evidence of higher epidural hematoma rates in other studies. One study quotes it as less than 1%. A systematic review found a rate of only 0.4%. And one study even noted that long-term outcomes are equal, even when a patient experiences an epidural hematoma. Individual practice varies widely. One study showed a wide range of answers when surgeons were asked when they begin chemoprophylaxis. So you can look kind of across the board, no less than 1/5 for each group. So it's really varied in terms of what people are doing individually. Same numbers again. And so I think there are limitations with this study, but it's really helpful. One is that there's mostly retrospective studies. There were no RCTs included in this meta-analysis. Additionally, there's inconsistent definitions across studies. There's differences in the patient populations, the treatments, their definition of major bleeding, even though they, in this study, used a wide definition. Each study might use different definitions. And the timing of anticoagulation. Of the 5 that were studied, that was less than 48 hours, but there were also an additional 4 that used different time points. Finally, it was predominantly in surgical populations, with only one study, including non-operatively treated patients, yet they did extend their conclusions to these non-operative patients as well. So in conclusion, the authors concluded that they recommended that they should begin chemical VTE prophylaxis within 48 hours, if feasible, because early anticoagulation reduces DVT and PE risk without any increase in bleeding or mortality. And their study supports timely prophylaxis and the need for standardized guidelines. These guidelines should still allow the surgeon to individualize prophylaxis based on bleeding risk and monitor them post-op. And overall, it does seem like both operative and non-operative patients will benefit. But I think it does bring up a few key points. One, whether this changes chemoprophylaxis prescribing, and then also if there are specific populations where we would want to change when we begin chemoprophylaxis.
Thank you, sir. I think this is a fabulous presentation that really highlights a topic that we often discuss. Personally, I think it gives me much more comfort and confidence prescribing DVT prophylaxis. But I also think that we all know that there are some cases where we know we're a bit more nervous, whether it was a patient who bled a lot during the case or patients who we did laminectomy where we know that the cord is exposed and we have those concerns. And so I really liked how you tied it all together and said that it provides some support to do early chemoprophylaxis, but also leaves us with the flexibility to evaluate each case individually according to that specific patient's risk factors. Yeah, and do you have any thoughts about this? I know kind of
We actually published on this, I forgot where, I think Journal of Neurosurgery Spine, just for spine in general. And we actually used a 24-hour guideline, and we did not identify any higher bleeding risk. In fact, we found a lower VTE risk with early anticoagulation. The problem was that the gray zone, we've talked about that several times, was that we could not identify either VTEs or the bleeds with or without anticoagulation to be causally related. The time of onset and the types of onset were just so dubious. There's just a population that is at risk, and we still don't know what the best chemical VTE prophylaxis actually is. It might be simple aspirin. You know, it might, there is not a fail-safe drug. We had people with VTEs who had proper low-dose Lovenox. We had people with VTEs who, when they left the hospital and were switched to an oral anticoagulant, had something happen there. So it's a pretty large study, I think 2,500 patients. In general, our government in the US at least would prefer us to anticoagulate patients and deal with bleeding later. That seems to be the general consensus. And I think the big open questions still remain as to 24 hours versus 48 hours. Clearly spinal cord injury patients, clearly oncologic patients, clearly patients with pelvic trauma need to be anticoagulated far more aggressively and monitored also for that. And the best chemoprophylaxis agent is still not known. So I'll turn the question back to the Bay Area. What is your recommendation in terms of the best possible chemoprophylaxis used?
So we sort of follow the data and anticoagulate early.
Yeah.
So especially for our spinal cord injury patients, well, actually all our spine trauma patients were anticoagulating at 24 hours, unless there's a strict contraindication. You know, even in our cases where we do laminectomies, there's always a concern in the back of your mind that you'll have a postoperative hematoma. We mitigate that by putting in multiple drains and monitoring the patient afterwards. So if they're spinal cord injury patients, they're in the ICU getting monitored every hour for neurologic exam for deterioration. If they're neurologically intact, we still get neurochecks every 4 hours. And with that, I've only had to take a couple, 2 patients or 3 patients back over the last 5-6 years for a postoperative hematoma. They were all identified early. All of them came back to at least or above whatever their pre-injury state was. And then that risk, we actually haven't seen any in the last 3 years since we've moved to our larger drains. Again, I completely agree with you, Jens, in terms of 24 hours versus 48 hours. We don't quite know. We usually just start at 24 hours.
Yeah, and I think you kind of bring a very good point anecdotally as well. I think I've had more issues with PEs and DVTs than I have with bleeding.
Yeah.
We are at time. Must thank you. Great articles by 3 great presenters. We'll just virtually applaud here. From classifications towards operative versus non-operative, towards anticoagulation questions and spine trauma, really very compelling topics, capturing the diversity of our problems that we face every day. Far greater detail will be available on December 19, Friday night, and Saturday, December 20th, under the leadership of Drs. Elnagaf and Dr. Gendelberg for our 11th annual spine trauma course. Really looking forward to that, and we hope that you'll come there. Ben put up the graphic there, so please register and participate virtually or in person. We'll have great labs and everything, and we'll have a greater forum with some really cool additional faculty to discuss all these points, with the goal of getting towards a more comprehensive and aligned treatment of spine trauma, from assessment to management. Today was a great overture with, again, 3 really cool colleagues who showed their dedication and their academic and clinical insights. And as always, thank you very much, Dr. Elnaga. Thank you very much, Dr. Gendelberg, for outstanding discussion and preparation. On behalf of Global Spine Journal, AeroSpine, thank you all and have a great weekend coming ahead. Take care.
Thank you.